Amrishi, are we live right now?
No, we are not live. We are doing it.
It is showing that live on YouTube.
Yeah, we
So
are
I
in
think
process.
directly you can put us on live. Put us on live.
Yeah. Give me 2 minutes.
The server will log in and then we will start.
Ritesh, we are live.
Okay. Thank you, Amrishi. Thank you. somebody from the name Reena has logged in. Sir, is it you? Amrishi, can you please add this the person for Reena? I think it is sir is trying to log in from a different. Yeah. Can you please add him as a panelist? Yes.
Yes. Hello, sir.
Hello. Hello.
Sorry, sir. Okay, now.
I think sir now it is perfect. Sir, so should we start?
Yeah, we can start that.
Okay, sir. So I'll just introduce you, sir, and then over to you. I just
Okay.
have a small introduction for you. Yeah.
Yeah. Would you like me to share the slide so that people can see what is there?
Yes, sir. Sir, I'll finish up the introduction. Then you can share the slide. Right, sir. Okay. So a very good evening to all of you. I hope all of you. I hope that all of you are safe and sound during this pandemic. Uh, I welcome all the doctors, all the esteemed participants, and our esteemed faculty, Dr. Keval Krishnan. I think when I talk about Dr. Keval Krishnan, I think as a formal introduction, Sir deserves no introduction. He is MS, DNB, FIACS, an advanced fellow of Mayo Clinic and Mount Sinai, USA. Sir is the director of heart transplant and ventricular assist devices at the Department of Cardiovascular Surgery, Max Heart and Vascular Institute at Saket. If I talk, yeah, if I talk about the other achievements, sir is the president of the International Society of Heart and Lung Transplantation. He's trained intensively in the entire spectrum of the ventricular assist devices, from bridge to transplant, short-term and long-term devices. Other areas of specialized training is ECMO. I think during this pandemic, a lot of reliability has been there on ECMO. He has had numerous publications and chapters in international journals and books related to advanced and complex cardiac surgical procedures. He's given multiple presentations in international scientific meetings for innovative techniques, and he's the reviewer of many publications of international journals. So we welcome Sir. We welcome, and we are really obliged. And on behalf of Curis Mankind Specialities, I'd like to welcome you. Thank you so much, sir, and over to you.
So I'm going to share my presentation with you. Thanks for the introduction, and I'm grateful to the Mankind Pharma to give me opportunity to speak on the novel compass for simplifying therapy and symbolizing compliance. As you must have been seen in this pandemic, the most important part why I'm presenting this, if you see in the pandemic, there were a lot of deaths due to COVID, but many deaths were due to DVT and formation of clot, and which goes to the pulmonary arteries and pulmonary embolism. Even the patients were on ECMO, and lot of these kind of patients, they were doing really fine, and then suddenly the embolus went into the pulmonary artery and heart arrest happened, and despite all the massage and nothing we could do. So this is one of the most important thing, that we need to use rivaroxaban judiciously, so that we can save many lives, as the third wave is also coming. So we should be very careful. What we have learned from the second wave, that it's not only the virus which was causing the problem to the lungs, which was advertised a lot, but the kidney, the coagulation system, everything. So many deaths were happened because of DVT, that led to the clot formation that went to the coronary, pulmonary arteries, and some patient with the coronaries also, because the clot formation was not only in the venous system, it was in the arterial system also, and a lot of patients, those were mild to moderate stenosis, they came with acute MI. So I'm Dr. Keval. I'm Director for Heart Transplant Program and Ventricular Assist Device at Max Hospital. I'm President for the Indian Society, and for the International Society, I'm a Program Committee member for assist devices and all these things. So understand the journey of this drug with the wide spectrum of indication. The rivaroxaban you development was developed in the beginning, and then dicomarols they came, and then warfarin came, and then low molecular weight heparin came, and then rivaroxaban and the other apixaban they came. So these are the recent developments with less. If you see, the rivaroxaban is with more benefit and less related to warfarin and acetylcholine, which were there, but we didn't have any option to give other drugs. So now we have rivaroxaban to give as a replacement with less complication, similar or better effects. So if you see the changing paradigm of anticoagulation, prevention, anti-DVT, pulmonary embolism, atrial fibrillation, and particularly non-valvular atrial fibrillation, it has shown a really good results, including the mechanical valves. So if you see the challenges associated with this vitamin K anticoagulants, this narrow therapeutic range, like this, I'm talking of warfarin and acetylcholine basically. The constant monitoring, you require INR, PT INR to be checked. If the patient, you never know it's the 1.6 INR or 2.4. So very close monitoring of these things. And if you are in the remote areas, then you may not be able to get access to these PT INR tests or the right tests. So you in rivaroxaban, you don't require such kind of stringent monitoring of INR or something like that. Slow onset of the effect, because like you start with the acetylcholine or warfarin today, and the effect comes after 72 hours, the peak effect, which is not rivaroxaban, not the problem with the rivaroxaban. Multiple food and drug interactions, like you can't take leafy vegetables with the acetylcholine, you are the tomato. So quality of life, we need to tell to everybody, don't take leafy vegetables because they interfere with the function of acetylcholine or warfarin. Intracranial hemorrhage, many patients come with the stroke, bleed in the brain, and then they present to us when they are well patient and they are on acetylcholine or warfarin. So approved drugs are dabigatran in 2010, rivaroxaban in 2011, and then 2012 and 13 the apixaban and rivaroxaban came. The direct thrombin inhibitor and factor A inhibitor. The rivaroxaban is factor 10A inhibitor basically. And if you see, the doses are different for different indications. The chronic coronary syndrome, it is 2.5 BD. And with the CAD and post-MI 2.5, and then peripheral vascular disease 2.5, and then atrial fibrillation 20 mg OD or 15 mg OD. Atrial fibrillation with stent, it's 15 or 10 mg OD. And if you see in the AF with renal impairment, it's a 15 mg. And with the DVT, it's again 15 mg for 21 days. If you see the characteristic of oral coagulants, if your rivaroxaban is 95% protein binding, means it stays for a while in the blood and maintains the regular level which is required for the body. And dose regime is only once a day. Rationale for using anticoagulant for cardiovascular prevention is, if you see the natural history of chronic coronary syndrome, it's a dynamic process. And with the stable atherosclerotic, if there is lesion, then 4-year incidence of MACE in such kind of patient prior to ischemic ASAP, ischemic event is 18.3%. Basically, for the holistic approach to the vascular protection, we do lifestyle changes, we have medical therapy or antithrombotic therapy. But to prevent the blood clot formation over the ruptured atherosclerotic plaque, you need to require something to be done to prevent the next level problem. So thrombus is made of both platelet and fibrin, and rivaroxaban is, it takes care of both, not only fibrin formation, but also it has platelet activation. It also affects the platelet activation. So it acts in two ways. It's a positive feedback loop in itself when it works in the coagulation system. So ACS management, it's for the right patient. It is used for with the treatment for the ACS is one. It gives a balanced benefit risk effect. And if you see the CV death, MI or stroke, rivaroxaban gives, if you compare with the placebo, rivaroxaban is better with the cardiovascular death. It is still better. And with the all-cause mortality, rivaroxaban has shown significant good results compared to the placebo. So there are minor problems in the body, but if you give such kind of rivaroxaban, then it reduces the not only the mortality, but it also reduces the morbidity when you give along with this aspirin. The vascular protective strategy for secondary preventions after the COMPASS this trial, if you see the rivaroxaban plus aspirin it's not only taken care of central system, but for the peripheral vascular disease, it has given a big benefit in a dual pathway inhibition are on the top of standard control of both for the stroke, for the MACE, for the MI, and in terms of death. It has shown really good results. Therapy that significantly reduces MACE in stable CAD and PAD. If you see the other drugs, they have no mortality benefit, but with the rivaroxaban plus aspirin, it has shown reduction in all-cause mortality. And the COMPASS tested the dual pathway approach. See, I don't want to go into this very busy slide, but the purpose of the efficacy and safety outcomes with aspirin and rivaroxaban, it has shown a really good results for the all-cause mortality, basically. And if you see the chronic cardiovascular diseases, who drives greatest benefit from the COMPASS regime, the overall population with the CAD, diabetes, renal impairment, heart failure, and CAD plus PAD, it has shown a really good results. That is why FDA has approved it as one of the key drug factor to prevent mortality and morbidity in such kind of population, high risk population. If you see the high risk should receive enhanced vascular protection in all the guidelines which have been mentioned, that it's a ischemic risk of diffuse multivessel disease. Even in the multivessel disease also, it has shown benefit to prevent thrombus formation or to reduce the major heart attacks along with aspirin. So it's an antithrombotic drug which prevent ischemic events. And if you see in the Indian context, the aspirin plus rivaroxaban in a younger age group, it has shown really greater benefit. And in India, if you see the incidence of such disease is almost 1 decade earlier than in the Western population. So it is a really good drug. All the cardiovascular related to thrombus formation population. In the company, the first long-term antithrombotic since aspirin to reduce the mortality like MACE, stroke, MI, bleeding. If you see the death rate, it has reduced 18%. So it is one of the important contribution to the important drug to the outcome. Only the coronary, but also the peripheral vascular disease. It prevents secondary prevention of the abdomen. Yeah, the in such kind of patient, it has it's a really good drug to prevent CV risk of CV and the limb event despite a guideline in the these kind of patient, it gives less morbidity, like limb ischemia. Things either can be prevented or can be prolonged. These things to prevent the poor outcomes. The high risk but few proven preventive strategies which they have used with the in such kind of patient as a
Sorry to interrupt you, sir.
Yes.
Sir, slides are not visible. I think screen sharing has stopped.
Okay, I'll now.
Yes, so now it is visible, sir. Now it is visible. Yeah.
So, so if the compass presented a new option, and aspirin synergistically target essential components of atherothrombosis. So it works on multiple sites to prevent thrombus formation. That is the point which I'm highlight. The dual pathway inhibit with the rivaroxaban and aspirin significantly reduces MACE by 28% and MIL by 46% versus aspirin alone. So it has significantly reduced major amputation by 70% versus aspirin alone. So these two drugs, they work as a wonder to prevent the major thrombus formation, which leads to ischemia or amputation in peripheral arterial disease. The way forward in 2021 is recently introduced long-term secondary prevention. Again, the same, this MACE, death, stroke rate, and MI. With the other trials, it has also significantly gave a primary endpoint a benefit of by 15%. So in the peripheral arterial disease. With the secondary outcomes are also in the secondary endpoint, it has also shown significant benefit. If you, I don't want to go into this slide. Rivaroxaban and ASA reduce major acute phase as well as in the chronic phase. When do you start the compass at a vascular clinic, the new diagnosis when high MACE risk are concomitant CAD, diabetes type 2, and other the EGFR and low EGFR, the high male risk prior revascularization or amputation, CLI, and the smokers. Multiple opportunities to enhance vascular protective antithrombotic therapy in patients with peripheral arterial disease. High-risk patient group benefit most with the treatment of rivaroxaban vascular dose plus aspirin. Basically, when there is a risk is high with the thrombus formation in any kind of population, rivaroxaban plus aspirin are good to go, whether it's acute coronary syndrome or atrial fibrillation. Atrial fibrillation with the non-valvular atrial fibrillation or with there is if there is any intracardiac clot also, then and it's standard approval rivaroxaban is 20 mg/d, low dose is 15 mg/d, and the patient with a patient with rocket AF, see there are multiple trials. They on the atrial fibrillation, they have seen that atrial fibrillation gives a problem. It basically due to atrial fibrillation, there may be clot formation or other things. Then it this to prevent the clot formation may be related to intracardiac thrombus, ventricular thrombus, or if a clot forms in the atrial appendage or anywhere else, it prevents the thrombus formation. It prevents the thrombus formation basically, and prevents the strokes, whether it's a stroke in the brain or the MI or the peripheral arterial ischemia. The net clinical benefit of rivaroxaban versus warfarin is greater in elderly population. and prevention of both AF and CKD increases with age. So it is also useful in the older age population. And when there is a liver evidence of preservation of renal function, rivaroxaban versus warfarin as now reiterated in guidelines, and a recommendation for prevention of thrombotic events in AF also. There's a similar thing that it's basically to prevent the thromboembolic events, whether it's AF or any disease which leads to thrombus formation. The recommendation for prevention of thromboembolic events in AF, it's one of the therapies to use it, and for the venous protection, stroke prevention, and vascular protection. Basically, it can be used in the venous thrombus, formation of clot in the DVT also. For prophylaxis can be used also to prevent the pulmonary embolism. It has shown a consistently safe result across most challenging populations, and effective treatment of frail and DVT patients with significantly reduced incidence of major bleeding. Treatment of DVT is rivaroxaban. As I already mentioned, that it's 15 milligram BD for 21 days is. In summary, I would say that rivaroxaban is one of the key drugs to prevent DVT, pulmonary embolism, intracardiac clot, or the clot formation due to AF, or with the mild to moderate CAD when there is a clot formation leads to major cardiac events, to prevent all these things. Thank you very much. For more information, you can go to my website, kevalkrishan.com. I'm sorry, I'll be there. Sorry for interruption. So, if there is any question, I am more than happy to answer.
Thank you so much, sir, for an enlightening talk. Sir, we have received around 4 to 5 questions. So, should we take all of them?
Yeah.
Okay, sir. So the first question that we have received, sir, they've asked about the doctor's name is not mentioned. So they've asked about the role of like 2.5 mg rivaroxaban, and how do you compare it with dual antiplatelets? Like there is a strong debate about whether to use dual antiplatelet or rivaroxaban plus aspirin. So what do you feel is better?
See, so far the results which they have seen in the COMPASS trial, elsewhere, all the studies, the rivaroxaban and aspirin together, it has given more benefit than with less adverse effects. Okay. So one should use aspirin plus rivaroxaban in most of the situations.
Okay. Okay. So basically the answer is clear there, that instead of DAPT, one should look at rivaroxaban and aspirin combination.
Yeah.
Sir, we have got a couple of questions. I think this is regarding the COVID usage. Sir, what is the response of 10 mg rivaroxaban in specifically COVID patients that are discharged from the ICU? Sir, how has been the usage like with them? So question is regarding
many were given like 15 milligram for 21 days. I would say this is the answer. Because this COVID is a pro-thrombotic state. Everybody knows. Everywhere, all physicians, all intensive care people, those who were treating the patients, despite giving the low molecular weight heparin, still many patients, they had this pulmonary embolism. May not be lethal, but to an extent, because we were doing almost 50 CTs, pulmonary angiogram, and for the pulmonary angiogram to check every day, I would say, just to check the pulmonary embolism whenever there is any risk of because you don't know whether it is because of lung or it is because of pulmonary embolism. the breathlessness, sudden onset of new breathlessness in the ICU is, or that reducing the patient becomes hypoxic or the saturation drop, sudden saturation drop, maybe due to lungs, less likely, maybe due to pulmonary, could be. So a lot of patients, they got CT, a pulmonary angiogram, and we found almost 33 to 40% of the patient, they had one or other, maybe major or minor kind of stuff in these patients. The component of pulmonary embolism. So, and this might have led to, like, few patients came with a MI, and it was found that they had COVID, and then the lesions were like 50%, 60%, 70%, but still they developed MI.
Okay.
They came as primary. So yeah, this is and many patients, the CT scan was done, and the contrast CT was, aortogram was done for some other reason, and they found that there were multiple clots in the aorta also, where there's a high pressure. Still, there were a lot of clots. So this was definitely a prothrombotic state. It's which could be controlled by low molecular weight heparin, but I would say if rivaroxaban might give a more benefit to this such kind of patient. Rivaroxaban plus aspirin.
Yeah. So in such conditions where you have like a prothrombotic state, 2.5 mg you would choose, or 10 mg? What would be the
I would
choice?
choose 10 mg for active up to 3 weeks at least. Not extending. Then you can go down on this if the patient has a high risk of developing thrombus, like patient with AF, patient with CAD, a history of CAD, family history of CAD, hypertension, or the other comorbidities associated.
Right. Sir, one question has come. I think this was a question which was expected. Sir, if the antidote is not available, how do you manage bleeding with antidote? If antidote is not available, then because for rivaroxaban, I think it is still not available with most of the brands. Yeah. So how do you manage bleeding?
If the antidote is not available, then, and another thing which I forgot to mention is if any patient who is getting rivaroxaban and the patient required urgent surgery, maybe abdominal, maybe cardiac surgery, then you can use cytosorb to remove that rivaroxaban. Cytosorb is good to remove clopidogrel as well as rivaroxaban.
So there, I think patient would be comparatively more safe, right?
Yeah.
Sir, what is the usage in SPAF and specifically if I talk about CNS embolism? So do you feel rivaroxaban has an edge over other NOACs? How is the usage like?
Could be because it has less complications. So like less chances of stroke, bleeding kind of stroke, then it's could be, it could be worth using it, but I think a lot of trials required to do the safety of this. We can't say now, but it is definitely useful for prothrombotic state if the patient has like carotid block, or it depends upon which kind of stroke patient has. So if the vascular obstruction is already, then it is definitely useful for that.
Okay. So one last question. I think this is a controversial one. That's why I think one doctor has asked this. Sir, what will you use ticagrelor for long-term post-CAD, or you would use rivaroxaban 2.5 mg PID? Madhav, it is basically they are asking what ticagrelor or rivaroxaban. So I think that is a controversial question these days.
See, other than it's a less than 15 ml of eGFR, if the patient has, if it is more than that, I would use rivaroxaban.
Okay. So it depends on the kidney function.
Yeah, it's only when it's your eGFR is way low, because 25, almost 1/3 is removed by the kidney. So if it is more than 15 ml eGFR, then I would use rivaroxaban over ticagrelor.
Right, sir. Sir, thank you so much. I think these were the questions. Thank you so much for your time. And on behalf of Curis Mankind Specialty, I thank you, sir, for a lovely talk and answering the questions.
I'm really grateful that you guys are really spreading this, because most of the patients, they are dealing with not only bleeding issue, with the thrombotic issues also. And particularly in the corona periods, this drug has come in the right time, I believe, that for the prothrombotic pandemic. So,
right.
Yeah.
Sir, after vaccine, this question is from my side. Sir, after vaccination, you see more results of more MI and clotting risk is more. After vaccination, are you seeing these kind of cases?
Not really. I have seen only 2 so far. Stroke happened to 2 patients after vaccine. Otherwise, no.
Otherwise, not.
Yeah, 2 patients developed stroke. That's what I've seen. Cerebral strokes.
So vaccination is safe.
Not
like, so
many.
far, so yeah.
Yeah, it is safe for sure. And it is useful that it reduces your morbidity if you come across, if you get infected. So yeah, that's vaccine is important.
It's important currently, right?
Alright.
Thank you so much, sir, for your time. Thank you. Thank you once again. We thank all the audience for attending and thank you for your valuable questions. Thank you.